everyone, my name is Yushan Johnny Lo. I am a second-year Pediatric Emergency Medicine Fellow at the University of Michigan. Today, I will be sharing my research on the trends in emergency department testing and management of hypothermic infants. I have no relevant financial or commercial interests to disclose. Serious bacterial and invasive viral infections have been found to be associated with hypothermia. The original limited research dates back to the 80s, with renewed interest within the last 5 years. Recent retrospective data, mostly single center, have shown a prevalence rate between 2 to 8% for SBI, with increased mortality in all age groups, both adults and pediatrics. While there has been extensive research into febrile infants over the last decade, there is a paucity of robust literature regarding the workup and management of hypothermic infants. Hence my research efforts to analyze the practice pattern in the pediatric ED for these patients. The objectives for this study were to describe hospital level variation in the pediatric ED evaluation and management of hypothermic infants less than 90 days old, and to determine the trends of CSF studies, inflammatory markers, chest x-rays, antimicrobial use, and emission rates over the last 10 years in hypothermic infants less than 90 days old. We abstracted data from the Pediatric Health Information System, or PHIS, which contains administrative data from more than 45 children's hospitals in the US. We then included patients with ICD-9 and 10 diagnosis codes for hypothermia, infants less than or equal to 90 days old presenting to the ED between January 1st, 2009 and December 31st, 2019. Our primary outcomes were ED performance of blood, urine, and CSF tests, chest x-rays, antimicrobial, and emission rates. We split this into 3 age groups: 0 to 30 days, 31 to 60 days, and 61 to 90 days old. Descriptive statistics were used, as well as chi-square testing, Spearman rank order correlation tests. In our cohort of 7828 patients, 81% were less than 30 days old, 85% of our overall cohort had CBC, and 70% had urinalysis tests, with statistically significant age group difference observed in chemistries, HSV, RSV, influenza testing, and cultures from all sites: blood, urine, and CSF. CSF tests were obtained in 50.9% of all patients. Similarly, chest x-ray was obtained in 39% of patients, antibiotics initiated in 79.5% of patients, acyclovir started on 40% of patients, and overall emission rate of 90%. Here is a heat map that displays testing frequencies for multiple tests in the ED at all the hospitals in our cohort, grouped into quintiles based on shade of black. Darker bars here indicate higher use of certain tests. For example, in urinalysis and urine culture column here, you can see that hospital 1 and 2 had a higher utilization rate than hospital 31 and 32 at the end here. Overall, you can see that there is a wide variation of testing and treatment, as there is a heterogeneous spread of black to white bars across all the hospitals within the PHIS network. As for my secondary objective, my results demonstrate trends in management as seen on this graph. Over the last 10 years, there has been a decrease in use of CSF and chest x-ray studies, a relatively constant antimicrobial use, and an increase in inflammatory markers utilization, which includes ESR, CRP, and procalcitonin. Overall, we found that younger infants had higher rates of most diagnostic tests and antimicrobial administration. This is most likely due to clinicians applying febrile infant guidelines to hypothermic infants, despite no robust evidence to support this. As shown by our heat maps, without clear guidelines for this population, there is a wide variation in practice pattern for the evaluation and management of hypothermic infants across pediatric emergency departments in the US. Hence, given this variation and risk of SBI and invasive viral infections in this population, prospective studies are needed to identify clinical and laboratory data for risk stratification and eventually create an evidence-based clinical practice guideline. This study does have a few limitations. The first is that the data were obtained from an administrative database without clinical data, such as specific vital signs, which prevents more granular analysis of clinical decision-making and indications for diagnostic tests and treatment. Since our query is based on diagnostic and procedural codes, it is dependent on physician billing encoders, which can vary from site to site. And lastly, since this was a retrospective study from a multi-center database that contains only children's hospitals, it may not be generalizable to or represent infants presenting in other settings. The other members of this endeavor are listed here: Dr. Rankopal from Northwestern and Drs. Rogers, Hashikawa, and Cranford from University of Michigan. Here are my references, and thank you for joining me for this session on the trends in ED testing and management of hypothermic infants.
Hi, I'm Nisha Narayanan, and I'm a pediatric ER physician at the Weill Cornell Department of Emergency Medicine. I'm here on behalf of the entire study team to present our retrospective, descriptive study on the utility of routine preoperative laboratory testing for supracondylar fractures in healthy children. We have no conflicts of interest to disclose. There's limited data on the benefit of routine preoperative laboratory testing in both the pediatric population and in orthopedic injuries. It's thought that preoperative lab testing is excessively ordered and often futile, particularly in previously healthy children with a low risk of requiring pre- or postoperative intervention. However, it continues to be common practice for many surgical orthopedic procedures. A number of institutions have adopted clinical practice guidelines intended to limit the variability in ordering practices and to reduce costs when clinically justifiable. However, compliance is highly variable and over-investigation occurs frequently. Examining the utility of these tests in specific situations can reduce unnecessary testing. Supracondylar fractures are the most common orthopedic injuries requiring operative management in children, and therefore they present an excellent opportunity for investigation. This study evaluates whether routine preoperative labs offer any benefit in the management of children who present to the emergency department with supracondylar fractures requiring operative reduction. We sought to examine A, how often these labs are obtained prior to surgery, B, how often these labs are abnormal, and C, the resultant use of blood products or case cancellations. We conducted a retrospective, descriptive study of all patients less than 18 years of age who presented to 3 diverse pediatric emergency sites from January 2010 through December 2018 with an ICD-9 diagnosis code of supracondylar fracture. We excluded patients presenting with multi-system trauma. Patient charts were reviewed to determine age, gender, the presence of routine preoperative laboratory testing, the number and type of laboratory abnormalities, the frequency of repeated routine labs, the presence of other fractures, and the presence of comorbid diagnoses. We defined routine preoperative laboratory testing to include complete blood count, basic metabolic panel, type and screen, and a coagulation panel, which included PT, PTT, and INR. We also assessed admission status, OR status, having a blood transfusion during hospital stay, and having an operative case canceled. SPSS was used to calculate descriptive statistics. We enrolled 156 patients in the study. 153, or 98.1% of these patients, presented with no additional injuries other than a supracondylar fracture. 69 out of 159, or 44% of enrolled patients, underwent operative intervention. Routine preoperative lab testing was obtained in 58 out of 156, or 37.2% of all patients, and in 54 out of 69, or 78.2% of patients who required operative intervention. The 54 patients who received routine preoperative labs were of mean age 5.2 years old, 55.2% were male, 17.2% had any past medical diagnosis, and 93.1% required operative intervention. The 15 patients who did not receive routine preoperative labs were of mean age 4.9 years old, 42.9% were male, 21.2% had any past medical diagnoses, and 15.3% required OR intervention. We found no comorbidity that was deemed to affect surgical outcomes, and therefore we did not conduct a sub-analysis of these at-risk patients. Among patients in whom routine preoperative labs were obtained, approximately 2/3 of CBCs and BMPs, 61.1% and 62.2% respectively, had minor abnormalities. The majority of CBC abnormalities were white blood cell counts and did not affect management or hospital course. The majority of BMP abnormalities were CO2 and potassium. Hyperkalemia was the only reason for repeat laboratory testing in 3 or 4.3% of patients in whom preoperative labs were obtained. Coagulation factors were obtained in 30 out of 69 operative patients, or 43.5%, and were abnormal in 5 out of 69, or 7.2%. There were no case cancellations or blood product use for any patients in this study. Originally, the study was intended to be part of a process of changing the culture at a single institution toward not obtaining labs for supracondylar fractures. Its limitations, therefore, included a small population, as we were limited to including only the past 8 years when the electronic medical record had been implemented. This was a retrospective descriptive study and not a predictive study. The study was performed at a single institution, although we did include 3 diverse sites across New York City, in both Manhattan and in Brooklyn. Lastly, we only studied patients with supracondylar fractures since it is the most common orthopedic injury requiring operative management. The study could have been expanded to multiple injuries. To conclude, routine preoperative laboratory testing was performed in most patients less than 18 years old who presented to our pediatric emergency department with a supracondylar fracture requiring operative intervention. They appeared to be of limited utility. The testing identified only minor abnormalities and was not associated with the need for an unanticipated blood transfusion or an alteration in care. Thus, the utility of preoperative lab testing is unlikely to be beneficial unless there is a factor which predisposes the patient to a higher risk of surgical complications and therefore necessitates them to undergo additional testing in the case that such complications should arise. Future studies are needed to further assess these outcomes among a larger population with additional injuries and using a predictive analysis. Thank you.
Good morning. I am Sonia Singh, Research Fellow in Emergency Medicine at UC Davis, presenting acute care costs of pediatric sports-related head injuries in Australia. This study was funded by multiple foundations and agencies in Australia and New Zealand. I have no financial relationships to disclose or conflicts of interest to resolve. In Australia, the age standardized incidence rate of ED presentations for pediatric head injuries was approximately 2,700 per 100,000 population and associated with acute care costs of $154 million in 2018 and a 13% increase over 5 years. The associated acute hospitalization costs were 117 million Australian dollars. The objective of this study was to compare emergency department and hospital acute care costs for children with head injuries due to sports activities in Australia. This was a cost analysis of acute care of a multi-center prospective observational study of 17,841 Australian children less than 18 years of age with head injuries of any severity enrolled between 2011 and 2014 across 8 emergency departments of government-funded tertiary care hospitals in Australia. Sports-related head injuries were identified using ICD-10 activity codes for ages 5 to less than 18 years of age, stratified into 2 age groups, the younger group for those 5 to less than 12 years, and older group for 12 to less than 18 years of age. Taking a public sector healthcare perspective, we applied costs from a single pediatric site to patient-level data. All costs were inflated to 2018 Australian dollars. There were 2,812 children between the ages of 5 and 18 years, or 15.8% of the study cohort, with sports-related head injuries. The mean age was 12 years, and 78% were male. The acute care costs were $2.7 million, with a mean cost of $954. 33% of injuries required acute hospitalizations and were associated with 76% of acute care costs, or $2 million. This chart shows the mechanisms of injury in decreasing order of incidence, with the attached parentheses depicting the percent of total injuries. The acute care costs are shown on the y-axis, with the percent of total costs shown at the top of each column. Bicycle riding was the most common mechanism of injury, occurring in 15% of children and associated with 26% of acute care costs. This was followed by skateboarding in 6% of injuries and associated with 17% of acute care costs. When stratified by age, 44% of children were in the younger age group and associated with 38% of acute care costs. Bicycle riding was the most common mechanism in this age group, accounting for 19% of injuries and associated with 35% of age group related costs. The older age group was associated with 62% of acute care costs. While rugby was the most common mechanism of injury, occurring in 15% of children, skateboarding in 7% of injuries was associated with 24% of age-related acute care costs. This was followed by bicycle riding in 13% of children, associated with 21% of age group-related costs. To conclude, in Australia, sports-related injuries account for 16% of head trauma in children ages 5 to 18 years. Injury prevention strategies should focus on age-related mechanisms to reduce sports-related head trauma in children. I would like to acknowledge my colleagues and PhD supervisors on this research project. Thank you.
Good morning. I will be presenting my research on the use of lactate as a predictor of pediatric submersion injury severity. I have no disclosures. To introduce the subject, according to the American Heart Association, submersion injury, more typically referred to as drowning, is defined as a process resulting in primary respiratory impairment from submersion or immersion in a liquid medium. In 2017, the World Health Organization cited drowning as the third leading cause of unintentional injury deaths worldwide. In 2018, statistics by the CDC demonstrated drowning as the leading cause of unintentional injury deaths in children between 1 and 4 years of age. Management of pediatric submersion injury typically depends on patient presentation and radiographic imaging. Disposition in the emergency department depends on status of the symptoms of the patient and their physiologic disturbances. Current literature shows that submersion time and CPR duration are best prognostic indicators for how the patient will do. To go over the methods of my research, it was a retrospective chart review of 151 pediatric submersion cases. Inclusion criteria included patients less than 18 years of age presenting within 4 hours of a submersion injury. Exclusion criteria included patients with severe pre-existing cardiac, pulmonary, or neurologic disease. The primary variables collected from each chart included things such as serum lactate and chest radiograph results, and secondary variables included patient demographics, circumstances surrounding the submersion injury, whether ICU was required, clinical outcome of the patient, and other such variables. Our objective was to determine if serum lactate had predictive significance in pediatric submersion injuries. This is a table of the data that we collected in our results. As you can see, the average age of the patients was 47 months, with a male predominance at 69% to 31% female. Of the admitted patients, 43 of them were admitted to the ICU. 136 chest radiographs were obtained, of which 60% of them were abnormal, with no association with survival to hospital discharge. 69 patients had lactate levels drawn in the ED, 60 of which survived to hospital discharge. Just looking at the p-values, there was no statistically significant difference between patients who survived to hospital discharge and those who did not, with regard to age, sex, location of submersion, whether or not the submersion was witnessed, or if bystander CPR was initiated. Interesting to note, the majority of submersions were actually in swimming pools at 87%. This is a graph of the survival to hospital discharge with regards to the mean lactate levels in the ER. Average lactate level overall was 6, with an average lactate among survivors at 5, while those who were non-survivors had a lactate level of 13. The mean lactate level in those who were admitted to the hospital was 6.5, and those who were discharged home, the mean lactate level was 2.7. All of these had significance with p-values less than 0.05. This is another graph of the area under the curve for lactate predicting mortality from submersion. As you can see, it closely approaches 1 at 0.97. Also to note, the area under the curve for lactate predicting admission to the hospital was also close to 1 at 0.83. In conclusion, from this research, we noted that higher elevations in lactate levels were associated with decreased survival to discharge, increased ICU admission, and increased overall hospitalization. Elevations in blood lactate may be a useful adjunct in identifying more severe submersion injuries. Some limitations of the study included the small number of enrolled patients, particularly those in the non-survivor subcategory. Secondly, due to the retrospective nature of the study, some of the data points were missing. Additionally, some of the unknown lengths of time for the submersion were noted or unknown, especially if the submersion was unwitnessed. A larger cohort study is recommended before this finding can be generalized to most cases of pediatric submersion injuries. Thank you so much.
Hello, my name is Tara Funk and I'm a second-year pediatrics resident at the University of Michigan. I will be presenting today on my team's research, The Landscape of Medications Administered Nationally in Camps. Can we be safe? I have no disclosures. Over 14 million children attend camp annually, and the American Camp Association, or ACA, is an organization that helps to oversee these camps. In the ACA's 2017 Emerging Issues Report, campers' health and safety, including medication administration, was identified as the #1 emerging issue, as millions of campers need access to daily and/or emergency medications while attending camp. Parents also report anxiety associated with campers' medical needs, and it has been shown that medication inquiries are among the most frequent questions posed to camp providers. A substantial knowledge gap exists in the literature regarding the types of medications being administered by camp nurses to allow children with medical conditions to attend. Therefore, we aim to categorize all medications recorded for one calendar year across 870 U.S. camps using one camp-specific electronic health record system. In order to accomplish this, we partnered with campdoc.com, an electronic health record that is specific to summer camps. It helps to manage information such as camper health forms, medications, allergies, and illness or injury reports. CampDoc.com provided us with de-identified data from 870 camps nationally to evaluate all recorded medications for the year 2019 for campers ages 5 through 17. My team and I, including a pediatric pharmacist, designed a coding book off which to classify our medications. We reviewed and classified all medications into categories and subsequent subcategories based on their mechanism of action and indication. Overall, we had just over 164,000 medications for 75,072 campers across the US attending 870 different camps. Camps were located throughout the states with a widespread distribution, including states in the Northeast, Midwest, South, and West. Approximately 56% of campers were female, 42% males, and 2% had either an other gender identity or had no gender recorded. The average camper age was 12 years with a standard deviation of 2.74 years. Medications were administered through a variety of routes. Most were administered by mouth at 70%, followed by inhaled medications at 13%, topical medications at 9.1%, injectable medications at 4.5%, and other, such as units or when no route was listed at 3.4%. For our primary medication categories, the highest proportion of medications fell into antihistamine and allergy agents at 23% with over 38,000 entries. Psychotropic agents followed at 21% with over 34,000 medications. And rounding out our top three were emergency and rescue agents at 12% with 20,000 medication entries. Other notable categories included over 11,000 entries for our herbal, supplement, and vitamin category. And the remainder of the top 10 are listed here. Notable medications that fell into subcategories included over 12,000 asthma rescue medications, 6,000 anaphylaxis rescue medications, 3,000 anti-seizure medications with 500 status epilepticus rescue meds, and 678 prescription pain medication entries. Overall, our results demonstrate the vast quantity and wide spectrum of medications that are used by campers nationally. In order to track, record, and administer these medications, a significant workload is placed on camp healthcare staff to ensure the safety of each camper, including in emergency situations where staff need to be able to react quickly and get the correct medication to the correct patient in a timely fashion. Both the volume and complexity of medication regimens leads to a considerable risk for medication-related errors. Further, the American Academy of Pediatrics and the Association of Camp Nursing have established practice guidelines regarding medication administration. However, they are not universally followed. Based on our results, we believe that in order to maximize camper safety, stakeholders need to work together to advocate for safety measures to prevent avoidable medical emergencies. By further researching safety protocols and implementing quality improvement strategies, the appropriate safeguards for campers can be provided and campers can continue to safely enjoy all the things that camp has to offer. Thank you, and I look forward to answering any questions regarding our work.
My name is David Sheridan. Thank you very much for having me this afternoon. And I'm an assistant professor of pediatric emergency medicine here at Oregon Health Science University. The title of my talk is Heart Rate Variability to Detect Worsening Suicidality in Adolescence, a pilot trial of wearable technology. I have no potential financial disclosures. This was funded by the National Institute of Mental Health K-12 Award Program. Suicide nationally costs $70 billion annually. Unfortunately, adolescents are a high risk and rapidly growing population. Suicide now accounts for the second leading cause of death in this age group. Adolescent ER suicidality visits have doubled in the past decade, now accounting for over 1.12 million visits annually. Mental health ED visits result in higher lengths of stay, higher cost, and impact the overall ability of the ED to function due to boarding. Unfortunately, after a first attempt, 1 in 5 will have a second attempt within a year, and repeat ED visits account for up to half of adolescent mental health ED visits. Care currently consists of validated scoring tools, but really require a patient to ask for help. Through a problem-based innovation approach, we aimed to identify continuously objectively monitoring worsening suicidality potential in adolescents with a past history to decrease ER visits and suicide attempts. The measure that we were aiming to look at with our technology was heart rate variability. Heart rate variability is the small, minute changes in the R to R intervals of an electrocardiogram, or in our use, a photoplethysmogram obtained at the wrist. Heart rate variability is significantly altered in patients with a history of suicidality versus those without in prior literature. In particular, heart rate variability is a measure of the autonomic nervous system, and suicidality has been postulated to have an imbalance of the sympathetic and parasympathetic nervous system. Prior studies have shown that vagal tone is inversely related to suicidality. So suicidal patients tend to have decreased vagal tone. Ideally, as their sympathetic nervous system ramps up and impulsive behavior begins, they unfortunately can't turn it down with their parasympathetic nervous system. So this study really aimed to look at the measures of parasympathetic activity through heart rate variability. This was a prospective study that enrolled patients ages 13 to 19 in both the emergency department and an inpatient psychiatric facility who presented with a chief complaint of suicidality or a suicide attempt. They wore our study device, which obtained, as I mentioned, photoplethysmograms at the wrist for 1 week, and during that time completed validated clinical scoring tools at days 1, 3, and 7. Those consisted of the Columbia Suicide Severity Score, which is really the clinical standard for suicide severity, as well as 2 stress tolerance scales. Clinical data included medications, prior history, escalations during the week, and things like that. Hypothesis was really that there was an inverse relationship in suicide severity and heart rate variability vagal tone measures, which is the high frequency component. As you can see here, we enrolled 51 patients with an average age of just under 17 years. There was a predominance of females, and approximately half had a prior ED visit or admission to a psychiatric facility. Unfortunately, 61% did present after an acute suicide attempt. As you can see here, the data was split very well between the emergency department and psychiatric facility enrollments. This is a table that shows the relationship between Columbia Suicide Severity Scores and the high frequency component of heart rate variability. This first row is all patients who came in on day 1 if they had a Columbia Suicide Severity Score greater than or equal to 15, which puts them in a very high category for your suicide severity. You saw that they had decreased heart rate variability parasympathetic measures in their high frequency component. We looked over time, so patients having a change in their Columbia Suicide Severity, and patients who had a 25% decrease in their Columbia Suicide Severity score showed an increase in the high frequency component of their HRV. You can see overall, there was no statistical changes. However, we did a sensitivity cohort, which looked at nighttime data because it eliminates most of the motion artifact and it's much more robust. You can see it's the exact same relationship, meaning higher suicide severity score, lower high frequency component, improving suicide severity, improving high frequency component, and those were statistically significant. This was a small study of 51 patients, so larger trials are needed. This did focus on regression analysis, so averaging high frequency component over a 24-hour time period rather than real-time machine learning types of data, which we've just submitted a K23 for. And this really focused on Columbia Suicide Severity Scores. We chose that because it is the clinical gold standard, but focusing more on return visits and outpatient care would be ideal. In conclusion, we did use a problem-based innovation approach to address a true clinical need. This is a technology platform to identify worsening stress dysregulation in patients at high risk for suicidality and actively engage loved ones. It may be a paradigm shift because we're introducing objective technology to mental health that potentially could decrease ER visits, suicide attempts, and provide just-in-time treatments. With that, I'm happy to take any questions you might have. Thank you very much.
Hello, and thank you for having me. My name is Dr. David Burkhardt. I'm an emergency medicine resident physician at Spectrum Health in Grand Rapids, Michigan. Today I'm going to be here talking about our research project, Techniques for Nasal Foreign Body Removal in the Emergency Department. I'd like to thank my co-authors, Dr. Oluwatosin, Dr. Zamaripa, Dr. Kalaki, and Dr. Jones for their collaboration on this project. Neither I nor any of my co-authors have any financial disclosures at this time. In the pediatric emergency department, nasal foreign bodies are a common complaint among patients. While it is a common complaint, it does not carry a high morbidity along with it. There are, however, few instances when nasal foreign bodies can be dangerous and require emergency removal. This includes both button batteries and magnets. In very rare circumstances, patients can aspirate the foreign body and cause airway obstruction, requiring more invasive removal techniques. In this study, we describe the experience providers have with various techniques for nasal foreign body removal in children who presented to an emergency department in West Michigan. We performed a retrospective cohort study looking at children under the age of 19 who presented to one of 7 affiliated emergency departments in West Michigan who had a discharge diagnosis of nasal foreign body. These patients were seen between December 2013 and November 2020. We recorded a number of patient demographic details, type of nasal foreign body, treatment received while in the emergency department, and the final disposition. After this, descriptive statistics and frequency tables were developed to help describe our data. Kappa was then used to assess inter-rater reliability. There were 1,145 children included in this study who presented with nasal foreign bodies during the study period. 39 different types of nasal foreign bodies were identified. The most common were beads, food, toys, and tissue or paper, followed by rocks, sponge, crayons, jewelry, earbuds, and coins. 3% of the study population presented with the more dangerous foreign bodies, button batteries or magnets, during the study period. The right nair more frequently had a nasal foreign body, and 3.2% of children had nasal foreign bodies in both nairs. 2.2% had more than one nasal foreign body in one side, and 2 children had both a nasal foreign body and an ear foreign body. 19 different extraction techniques were utilized throughout the study period. The most common was the nasal balloon extractor, or the CATS extractor, which was used in 47.7% of cases. Next up was suction, followed by alligator or bayonet forceps, positive pressure applied by the parent or child, hooked probes, ring curette or wax loops, hemostats, tweezers, saline irrigation, nasal aspirator, and a Q-tip. Throughout the study period, providers had excellent success at removing nasal foreign bodies. 73% of cases, the nasal foreign body was removed on the first attempt. 19.7% of cases had successful removal on the second attempt, and 7.3% of cases required 3 or more attempts. Complications were present but not very common. 46 children, or 4% of the study population, had complications which included mild epistaxis, swallowing of the nasal foreign body, sneezing, pain, and posterior displacement of the nasal foreign body. Throughout the study population, 14 of these children required sedation for the procedure, and 39 children were referred to ENT. Kappa value was calculated to assess inter-rater reliability and was excellent with a Kappa value of 0.89. This descriptive study shows that there are a number of possible ways to remove nasal foreign bodies in children that include simple removal techniques. The choice of technique depends on the location, age of the child, the type of foreign body, and the clinician's comfort with the removal method. These methods do not take much time, and they do not require complex equipment. We also note that the first attempt at removal of the foreign object is the one most likely to succeed. Thank you for watching this presentation, and we welcome any questions at this time.
Thank you for joining me at SAEM and giving our team the opportunity to present stress testing the predictability and stability of a pediatric emergency care applied research network rule. The Pediatric Emergency Care Applied Research Network, or PECARN, developed and internally validated a clinical decision rule to improve the evaluation of children after blunt torso trauma. However, these decision rules have not completed a resource and time-intensive external validation. The predictability, computability, stability data science framework is an established unified data science framework.
PCS has been used in drug response prediction, however, has not been used to evaluate or stress test clinical decision rules. In this study, we sought to assess and improve the PCARN clinical decision rules using the PCS stress test predictions, and then compare the PCS stress test performance on an independent external data set. To evaluate clinical decision rules, we took a novel approach by creating a stress test to shake out, perturb, or evaluate the performance accuracy of clinical decision rules at both the variable and model level. To do this, we took a holistic approach. First, we reevaluated the clinical problem. Next, we collected and pre-processed the data by splitting the PCARN dataset into a development and internal validation dataset. Third, we modeled 5 new clinical decision rules. Fourth, we assessed model and variable level performance. And last, we interpreted our findings by comparing the PCS stress test rankings versus external validation. Here is what we found. On the left, you will see a sensitivity specificity curve for the newly developed models. The performance accuracy and stability was then ranked, showing the original PCARN clinical decision rule in black being the highest performing, and the iterative random forest in red being the lowest performing. We then compared these findings to how the clinical decision rules actually performed on external validation. What we found was that the ranked order of the PCS stress test was the same ranked order found on external validation. Similar to the model level performance analysis, we also evaluated each predictor variable. We used the frequency and the non-zero permutation importance score to PCS stress test each predictor variable for both predictability and stability, which can be seen on the top left. What we found was that the PCS stress test ranked 3 variables as the highest performing: visible abdominal trauma, Glasgow Coma Score, GCS, and abdominal tenderness. On the right, we ran the PCARN clinical decision rule on the external validation dataset. We found that the top 3 predictor variables in the blue box, including visible abdominal trauma, GCS, and abdominal tenderness, corresponded to all the predictive power of the clinical decision rule. That is, the other predictor variables in the red box had none of the predictive power of the PCARN clinical decision rule on external testing. Therefore, in conclusion, we found that the PCS stress test correctly identified the PCARN clinical decision rule as the highest performing clinical decision rule. We also found that the PCS stress test is a novel method of assessing and improving new clinical decision rules before further investment in costly external validation. Thank you to my co-authors and collaborators, including UC Berkeley, PCARN, PEDSRC. Also, thank you to SAEM for giving us the opportunity to present our findings.